This podcast is supported by IHI, also known as the Institute for Healthcare Improvement, who have been improving health and healthcare worldwide for 30 years. Those of you familiar with IHI will already be aware of their work to make care continually safer by reducing harm and preventable mortality. Patients and patient safety are at the heart of what IHI does, and that's why IHI encourages the use of the SBAR technique. SBAR stands for Situation, Background, Assessment, Recommendation, and they've developed a tool to help foster a culture of patient safety in any health and healthcare setting. Learn more and download the SBAR tool at ihi.org and start using it today. While you're there, check out the many other tools and free resources available from IHI, including QI tools, health equity reports, and patient safety tools, to name a few. That's ihi.org. Check it out today. Welcome to CareTalk, America's home for incisive debate about healthcare business and policy. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrix. David, who do we have today?
Well, you know what, John? We have Edo Banach. He is president and CEO of the National Hospice and Palliative Care Organization, and he's a former official of the Center for Medicare and Medicaid Services.
Hey guys, great to be on.
Welcome, Edo. Edo, can you maybe start? We both know that palliative and hospice care is an essential part of an integrated healthcare system, which we don't have. But maybe start by, if you don't mind, introducing us to kind of what is palliative care and what is hospice care and what's the difference.
Sure, happy to do it. And to ground ourselves, let's just kind of go back a little bit to the 60s in England, which was a swinging period, but also a time when the hospice movement really got its start with Dame Cicely Saunders at the St. Christopher's Hospice. And the movement sort of migrated across the pond, started out with the Connecticut Hospice in the late 60s, early 70s. And by about 1978, we had a Medicare demonstration of the hospice benefit. And it would be 4 years before that hospice benefit sort of became part of the law. And all that took a lot of work in Congress and at what was then HCFA and ultimately a CMS. But really, in the beginning, it was a hospice benefit that was established in this country. It's important to recognize, though, that although all hospice care is palliative, not all palliative care is hospice in this country. Contrast that with the rest of the world. In the rest of the world, hospice really doesn't exist in much of an organized way, and what we call hospice is called palliative care. Confused? Yes. So the bottom line for this country is that we have an organized hospice benefit that's in law, and we have a palliative care benefit that we speak about that's much broader, that exists in institutions as palliative medicine and rarely in the community. And that's something that we're starting and trying to build.
And so what is palliative care?
Well, palliative care is ideally interdisciplinary, person-centered care, either in an institution or in the community, that is really centered around what the individual needs. It could be medical, it could be social, it could be psychosocial, but the idea is, and I want everyone to sort of draw a kind of a picture in their mind. But this is a picture that Dame Cicely Saunders actually drew. You have a person as the hub, and you have a series of spokes around them. Those spokes are their various needs. Around those spokes are other circles. Those are the people who meet those needs. Some of them are social workers, some of them are nurses, some of them are chaplains, and some of them are physicians. And that is a good definition, I think, both for what the hospice benefit is for a limited amount of time at the end of life, and what the palliative care benefit is for a longer period of time further out from the end of life.
I want to actually pick a fight with you on that one, though. I think what's remarkable about palliative care is it's one of the only areas of healthcare where you start with, what does the patient want? And for me, it's, in addition to being whole person focused care, you actually not just look at what they need, because the hierarchical healthcare system often tells you what you need, or defines it. Most extreme situations in some countries like Japan, where they don't even necessarily tell you how sick you are, or the historically what you were sick with, to a hierarchical system, to one where actually palliative care starts with what does the patient want, and addressing the whole person. And I just think that's what's remarkable about it. Sort of grounds, I think, what healthcare could be if it's kind of built around the humans as opposed to the healthcare industrial complex.
You're not definitely not picking a fight with me. I completely agree. I think that, it starts with what the individual wants. And that want is kind of defined by folks being educated about what their options are. And the options shouldn't just be limited to the poking and prodding stuff that you can get in the institution. It should be much broader than that. So the typical example is, I want an air conditioner. It's not a luxury that's actually going to keep me comfortable and at home. How can the system actually pay for that instead of having me decline to the point where I need to be in an air-conditioned place called a hospital?
So there's a lot of things that came over from England in the 60s, and a lot of them sort of have moved and evolved since then. So what's happened since it made the jump over the pond?
Well, the most significant thing that happened since then is, first of all, the hospice benefit itself grew, became a part of the Medicare program. There are good things about that. We have a defined benefit, and people are able to access it. We have bad things about that. It's kind of a limited box that we've built. It's also important to recognize when the hospice benefit came over not the pond, but moved north to Canada, that's when the words palliative care were actually coined by a physician named Balfour Mount at McGill. So palliative care, because hospice doesn't translate well into French, palliative care came to mean hospice plus a more expansive set of services that were available either in the hospital or in the community further out from the end of life.
I always wondered what the Balfour Declaration was, but now I think I understand it. And so what about the, on Medicare? Because the other thing, they didn't at this time.
Don't let Edo get out without describing exactly what, like from a person-centered, Edo, what is this thing called hospice? For those who don't really understand it, what is the hospice part of the hospice benefit?
Sure. So the hospice part of the hospice benefit, as currently defined in the Medicare statute, just requires a couple of central things. First of all, interdisciplinary care, a whole bunch of different people providing a whole bunch of different kinds of care for individuals who have a prognosis of less than 6 months to live, importantly, and it is not curative care. It is, in order to choose hospice care, one has to give up curative care in order to receive the palliative care. So lack of concurrent care, prognosis of less than 6 months to live, and interdisciplinary care. The other part, which is kind of the secret sauce of hospice care, two other parts, actually three. One is more than 5% of the workforce needs to be volunteers. That's number one. Two, individuals and their families or loved ones get access to care. It's not just the patient; it's the patient and the family that's the unit of care. And related to that, after an individual dies, their family or loved ones get grief and bereavement support for an additional 13 months. So what I just sketched out is the kind of the Medicare definition of hospice care.
And how broad is this workforce? I mean, you mentioned, volunteers, family members are involved too, but are there other sorts of non-traditional sorts of therapies that are provided?
For sure. So this is the original kind of flexible, kind of, in a sense, managed care benefit, because there are certain required members of the interdisciplinary team. So that would be a nurse, a social worker, a couple of different kinds of therapy, a physician, medical director. Those are some of the required members of the interdisciplinary team. They're in the conditions of participation. But there are also sort of non-required members of the interdisciplinary team, such as art therapists, music therapists, and other kinds of therapies that can be used and should be used, actually. I went to an event just last week on art and music therapy, and the difference that music therapy can make at the end of life can sometimes match morphine in terms of pain. So definitely into all kinds.
I have a question about that too, but John, you go ahead. You interrupt my interruption first.
Yeah.
No way. I mean, I know you were hanging out with the French ambassador, and I know you were talking about music therapy, and I know that you're as a committed artist yourself, musician yourself, you're kind of biased. But really, drugs versus the banjo?
Well, so I used to think that too. And it's not the banjo. It's not someone walking around and sort of strumming an instrument. It turns out that when you look at the literature, the breath of an individual, the way in which they literally breathe can be affected by the speed of the music or the tension and the release of the music. And studies have shown that art therapy generally and music therapy specifically does offer pain relief. And I think that it's really important, if we're going to be kind of interdisciplinary and kind of non-medical, non-poking and prodding, to really have an open mind with respect to all types of things that can relieve pain at the end of life. Is morphine important? Absolutely. But it's one of the tools, it's one of the arrows in the quiver of the interdisciplinary team. And it's for the same reason. Certain people can be touched by chaplaincy and spiritual care. And for other people, it's irrelevant. Same thing. Some people benefit from music or art, and other people benefit more from some other things. So it's really important, again, if we're going to be person-centered, to say what does the individual want, and what are they going to respond to? What's going to be effective here? And those are all things that hospice and palliative care have at their disposal.
Well, John, I knew you were going to ask the one about music, and I saw that your remarks about, it's not just sort of the strumming of the guitar and all that, but I mean, as I understand, you're a drummer. I mean, to what extent is like drumming and hardcore drumming a part of the palliative or hospice experience?
Well, I would say it's funny. I was at an event also last week, and somebody came up to me and they said, "Hey, aren't you that drummer?" Yeah. And I kind of smiled and I said, "Yes, I am." But the reality is anything that in the arts can be a part of palliative care. That I don't mean to diminish the science of medicine. But the reality is that, sitting around in a drum circle for someone who has dementia can sometimes be therapeutic. So I'm really, and I'm not coming at this from a kind of high level sort of artistic sort of perspective. But the reality is it's the rest of the healthcare system that's poking and prodding people and over medicalizing people. And I think that as people get seriously ill and as they develop all sorts of social and psychosocial needs, there are many things that end up working.
Well, and I was giving you a hard time and about to make some snarky remark about the Clash, but should I stay or should I go? But it's a at the end of the day, there's no question whether it is music therapy or art therapy or working with animals that the what is so exciting about palliative care and at the edges hospice, which is really more end of life, is we're bringing the full person emotionally, spiritually, they're back into the curative care loop. And what I find remarkable is how often the care that's designed to make people present and comfortable at end of life can often extend life because you're addressing the whole person. It's really, and and we're just, we're this between 2016 and 2060. You probably know these statistics, Edo, better than I. We're going to go from, I don't know, about 40 or 50 million people over the age of 65 to over 100. It's fastest growing part of the population are people who are going to have multiple chronic conditions. And so we as a healthcare system have to get better at this. I think 39-ish% of all people in their lives will get cancer. And the cancer is much more prominent in parts of the world where people are living longer and we're doing a really good job extending life. If we're going to extend life, we have to get this combination of care right. But I think it's really exciting. And I think what you are doing in palliative and hospice could have lessons for curative care much, at a much earlier stage that isn't end of life.
Senator, what is your question there,
Well, let me answer a question you didn't ask, which is so what can we do here? What changes do we need to both the hospice and palliative care benefit, really the entire system, in order to make sure that we have enough people to actually care for the folks who need care? Because we're running out of money and we're running out of people. So here's what I would say to that. First of all, right now we have a hospice system that was designed to care for the people who are dying in 1982 or 1978, not now. More than half of the people who receive hospice care right now have dementia, not cancer. And it used to be more than half had cancer. So the old rules that say you can't have concurrent care, you can't have curative and palliative at the same time, you have to have a prognosis of less than 6 months, don't really work well for dementia. Why? Because people could really live a long time, and we treat that as if that's a bad result. So the hospice is demonized and made to discharge these patients into the rest of the healthcare system, which, as you just said, really isn't designed to meet their needs there either. So one, change the hospice benefits so it allows for concurrent care, which has been tested. Turns out it doesn't actually cost more money to give people access to palliative and curative at the same time. So that's number one. Yeah, go ahead.
No, so, I was going to say, I think you've been a proponent, there's this Medicare Advantage hospice carve-in, and then I think you're talking about like the Medicare Care Choices model. And, is that where things are going? And it sounds like, on the one hand, if it's higher quality and it costs less, you think it would be adopted. On the other hand, the way our system works, maybe that's going to be its death knell.
So I would say that, right now, the Medicare Advantage program is in an interesting period with respect to palliative care, non-medical supports and services, supplemental benefits. The benefit is sort of whatever they say it is. So I think we're definitely going in a direction of more of these benefits being available through Medicare Advantage. As a former government person, I think it's really important that we help to define those benefits. So we've been talking about palliative care now for about 15 minutes. What's the definition of palliative care? Well, there's one in the hospice statute. There is no community-based palliative care benefit that one can wrap their arms around and say that's the definition. So if Humana has a benefit and United has a benefit and Anthem has a different benefit, is that a good thing? Well, maybe, but we should at least have a bottom line, a standard below which you cannot dip and still use the words palliative care. And so that's been our perspective.
As I don't think it's a good thing. That's why we at the CareCentrix, our serious illness program really is a social first, clinical second model,
right?
But has certain standards, because I think without that, in a world world that's kind of backward looking in terms of innovation, which is typically healthcare, I don't think we're gonna pull people forward to atypical forms of healing unless you set that standard. And what I'm excited about in the Medicare, with a distinction that I think, David, you were trying to draw, is that the hospice,
however clumsily, but yes, go ahead.
The hospice benefit, where we would actually integrate an end of life benefit into Medicare Advantage, but doesn't address that curative piece. Was sort of, there's this other model of the Medicare, I think it's the Medicare Choices model, where you're actually permitted to get access to curative care. Can you talk a little bit about that? Because too much, I think, of this palliative is mistaken for hospice. Hospice is sort of a fire and forget economic model where you've got 6 months to live and we're just going to push you over here. But there's this new model that the research came out and it was pretty interesting. Can you just describe it? Because it's pretty interesting.
Yeah, and actually the Medicare Care Choices model, and I was at CMS, I was on the selection panel for that, stands for the proposition that you can actually receive hospice-like and curative care at the same time. So the conventional wisdom at the Office of Management and Budget was, look, if you give people access to curative care and palliative care and hospice at the same time, then you're going to double your spending, or at least you're going to spend more than you would have otherwise. What the research shows is that's wrong because of your point, John. When you give people access to all of the kind of the pieces in between the rusty sort of healthcare system that doesn't work, all the things that they've been wanting, more psychosocial supports, more care in the community and all of that, they seek more of that and less of the poking and prodding on their own. They self-select. And so what ends up happening is, my mother, for example, has stage 4 cancer. She should be on hospice. The reason that she's not is because she doesn't want to admit that she's dying, and she doesn't want to give up curative care. But there is no curative care. It's more of a psychological issue than it is a medical issue. And once you say to that person, you're not giving anything up. You can still have all that stuff anytime you want, but you can also get all of this stuff anytime you want. More people choose that. There's another thing that I think is really
important. And it's cheaper. I mean, I really want to underscore, you've been making this point, but I don't think people have internalized it, that when you give people access to whole person care, the medical industrial complex costs less. It's profound. Yes. It's really exciting. David, get excited.
Yeah, absolutely. I mean, I think that's precisely true. It's also true, I think, that in terms of equity, there are groups of folks who have been traditionally kept out of the healthcare system by the medical industrial complex. And we're talking to groups who have been traditionally kept out of the medical industrial complex and saying to them, you know what, give all that up. Now that you're at the point where you've actually accessed that care, in order to get all of this care in the community. And I think that's a really hard pill, no pun intended, to swallow. So if we take away that hard choice and we say, not only in palliative care, which we're going to define and create the benefit, right? We're working actively on that. But even in hospice itself, then we're actually going to see that more people get more of the care that they need at the right time.
I think we should insist on that as a right. I mean, David, why are you so quiet on this issue? It's important.
I enjoy it when you get all kind of wound up and worked up. Before, I thought, where you're going before, I was going to have to reach over and get a tissue because it was such a nice story that you were telling. But I like it, righteous indignation. But I want to ask something about something a little more complicated. Medicare is complicated enough, but what about when you bring in Medicaid and deal with the dual eligible population? How does that all work together?
Not well. As you know, I used to be the deputy director of the duals office, the Medicare-Medicaid coordination office, and you would expect that if someone has hospice care, that benefit would sort of work really well with whatever they might have under Medicaid. Unfortunately, it doesn't, and it doesn't for the personal care benefit that Medicaid has especially. So you get, and not to get in the weeds too much, but you get access to aids through hospice. You also get access to personal care aids through Medicaid, especially if you live in a place like New York. And sometimes those two benefits, although they should work together, don't work well, and people end up having to figure out which aid to keep under which benefit. We're working to fix that problem with my former office, but it's one of those bump ups that unfortunately occur.
Edo, a different question. Okay, we've got this. Let's say we are successful at providing access to all of this psychosocial, person-centered care, even in the curative system. Right. Where are we going to find the people? I think that's a really powerful question, and I didn't know whether you had any ideas or policy recommendations.
Yeah, so policy recommendation number one: let in any body from Russia or Ukraine that wants to, provide support in this country. And I'm half kidding, but I'm half not. This immigration is going to have to play a role here, especially when it comes to nurses. We have a broken immigration system. I think there is bipartisan support for making some changes, but we've been unable to do that. We've got to get past that. And that, unfortunately,
10,000-ish medical professionals stuck in the immigration system right now that aren't moving.
Right, and many more that would love to be stuck in the system. And so, one, I think we need to make some changes there. Two, I think we are still quite proprietary, and territoriality sort of plays a role. Only nurses can do this. Only social workers can do this. Only nurse practitioners or physicians can do this. We have the scope of practice has to be made more flexible. We don't represent physicians or nurses. We represent the enterprise. We represent the people who get the care. So we need more flexibility when it comes to that as well. And then we need to prioritize the personal care workers, the folks who are really the backbone of both the Medicaid and, I would argue, also the serious illness system. You should not get paid more working at Amazon than you do being a personal care worker. And it should be a priority to figure out how to massively increase their compensation so that we can actually compete. And then we'll find the workers.
So other than immigration dropping off over the last couple of years, any other impacts from the big global pandemic that has been among us as it relates specifically to palliative care and hospice?
For sure. I think burnout. I think folks are burnt out. And I think the great resignation that we've seen across the country hasn't spared the hospice and palliative care community. Folks are worn out when you're dealing with serious illness. Folks are dealing with serious illness, but when you add COVID and all the related restrictions that came along with it, it really took a toll. Cost, when the price of gas is $5-6 a gallon, and people have to drive from homes that might be 25 miles apart. Remember, hospice gets a fixed, essentially capitated fee.
Yeah.
So anything you do has to be within that. So it's been a really tough time for the workers. But I think, and I'm cautiously optimistic that we're going to see some progress in the next couple of years, and we'll be able to provide for the workers, and we'll be able to really build the palliative care benefit that our folks deserve, and then also provide flexibilities in the hospice benefit, which has been stuck in time for about 40 years.
John, last question to you.
So, Edo, what's the best music therapy that David and I should try that'll help heal us and our families if we're going through a period of difficult illness? It's a really fascinating area.
Absolutely. Well, I think that people swear by classical music and its impact. I will say this though: I visited a patient once with a music therapist, and we get in there. It's an older African American woman, and the music therapist asked her what she wanted, and she said Johnny Cash, and she started strumming Johnny Cash. And the woman sort of was responding, but not really. And I was speaking to her son, who told me that she used to be in the church. And I said this to the music therapist, and she played a song called "All Other Ground Is Sinking Sand." And I'm at spiritual, and I'm a Jewish guy. I have no idea what's going on. But I was so moved by this spiritual that I started joining in. So I think it all depends on the person. Just like care, music is person-centered, and what ends up moving folks is amazing. If I were to pick one, it would be Schubert. But the sky's the limit in terms of what's effective. For me, I would go for jazz.
I don't know. I'm with Johnny Cash. Will the circle be unbroken?
Johnny Cash,
David.
Okay. Well,
that's good. Well, I've got nothing. We'll just consider that's going to be, an additional service we offer here on CareTalk. You can record your advance directive, at least as it relates to music. But I want to say, Edo Banach, President and CEO of the National Hospice and Palliative Care Organization. Thank you for being a guest today on CareTalk.
Edo, I always enjoy hearing your thoughts. You're helping us actually bring some civility and heart-centered care to the healthcare system. Keep doing all the great work you're doing and pulling us back towards our roots as humans. Maybe that'll heal all of us. Thanks for joining us.
Thank you, John and David. Appreciate it.
Great. Well, I'm David Williams, President of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrix. If you liked what you heard or you didn't, please subscribe on your favorite service.